Hello, and welcome to today's presentation, Mental Health Trends for Payers and Employers. We're going to get started in just 1 minute as we see attendees still logging into the On24 platform here. So we'll just wait for a minute here, and in the meantime, have a look around on the resources list, on the Q&A, on the console itself, and ask your questions for follow-up later in the presentation today, and we'll get to them. So we'll be with you in just a minute here. All right. Hello again, and welcome to today's presentation, Mental Health Trends for Payers and Employers. Thanks so much for joining us on what I'm sure is a very busy day for all of you. Before we get started, I'd like to review a few of our housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 24 hours. If you have trouble seeing the slides or if you're experiencing any audio difficulties or video difficulties at any time during the presentation, please first try refreshing your browser. If you have any issues during the presentation that's not solved by refreshing, click the help button at the bottom of the console. It looks like a question mark. You may ask a question at any time during the presentation by typing your question into the Q&A box located in the presentation console and pressing submit. We'll do our best to answer all the questions by the end of today's presentation. There will also be resources that you can view at your convenience available in the resource list on the right-hand side of the presentation console. There will also be a poll during today's webinar, so when that poll appears, there will be an alert, an audio alert. You simply will click the responses and hit submit. Make sure to scroll through all the options before submitting to make your voices heard. Without further ado, I'm going to first pass this along to Manny Vega, our Senior Product Marketing Manager for Health Insights here at Merative, and then we'll get to our presenters. Take it away, Manny.
All right, thanks very much, Adam. Thanks everyone for joining. I'm really excited to introduce the team that's going to be presenting today. They are all members of our Applied Analytics and Consulting Services team here at Merative, and they work with clients to provide proactive advisory, research, and much more, really to help our clients evaluate their population health trends and dig into the data and identify ways to address their own goals. And so today's webinar is really going to draw on all of their collective experience from helping our clients as well as from their careers. And so just in order here, I'll introduce Leah Kamen. She is a member of the team, 14 plus years of experience in healthcare, including as a oncology clinical researcher and a healthcare quality researcher. We'll also hear from Brandy Hodor, who has more than 2 decades of experience in healthcare strategic planning. And she is an industry expert in sociodemographics and social determinants of health. Mihil Senatharaja has over 20 years of experience in health services consulting and research, and he is a subject matter expert in comparative performance measurement for public reporting and value-based payment purposes. And we've got Becky Nihas. She has over 15 years of experience working with healthcare data in data management, product management, and analytics. So personally, I'm very excited to hear from our panel on mental health trends. Of course, we all know it's a very hot topic right now, something that we at Merative heard brought up at all of the different trade shows that we went to this past spring. And as I said, it's one of the many topics that Merative tracks on behalf of our clients as well. And so I will explain a little bit about Merative here on the next slide before handing it over to our presenters. We have been in the healthcare analytics space for over 40 years. You may recognize us by one of our previous names, Truven Health Analytics, IBM Watson Health, several others as well. About 1 year ago, we were acquired by Francisco Partners and became Merative. And so I'm excited to say today that we are fully independent in the healthcare space, privately owned. We have very deep experience in the healthcare regulatory environment. So really when you work with Merative, your data is in very good hands. We also have 4,500 customers across all of healthcare. That includes top organizations in the Fortune 100, 7 of the top 10 US health plans by enrollment, and 70 plus state, local, and federal government agencies. And so, I really say all of that to say that everything that you hear today from our panel of experts really reflects those 40 years of experience and all of that ongoing work in this industry. We also have a portfolio of data and analytics solutions, including Health Insights, which is our healthcare analytics solution used by health plans, employers, government agencies. Many of the trends in the data that you'll hear in today's webinar actually come from MarketScan, So MarketScan is a Merative product. We're the only analytics vendor in the market that has complete access to that de-identified data set of closed claims, and it represents more than 293 million covered lives sourced from a diverse pool of payers and employers. And final point I'll make, we work with clients in a variety of different ways, really try to be flexible to meet clients where they are. We make some of those MarketScan data sets available to customers who choose to license them. Some choose to license our methodologies as well, which are built into Health Insights. Health Insights offers the power to benchmark against MarketScan at the national level, the state level, local level, industry level. And we are constantly creating new predictive models, advanced methodologies to support our clients. Some just choose, as I said earlier, to license data. Others might get the full end-to-end analytics solution. And so most importantly, we're a strategic partner to our clients. And so I think a lot of what you hear today from trends in the data and the examples that we cover are really examples of some of that strategy that we provide. So with that, I'm going to hand it over to Leah, who will get us started on mental health trends.
Thanks, Manny. I'm excited to be here today. So on this slide, we're going to talk about how mental health is a key focus for employers and health plans. I don't think that's a surprise to anybody here today, but what does that mean? Well, in a Willis Towers Watson survey of 455 U.S. employers, 2/3 plan to make mental health programs and the solutions that support it a priority over the next 3 years if they're not already doing so. Accordingly, health plans have been offering additional behavioral health offerings, expanding provider networks, and improving quality of care transparency, and largely increasing access through virtual care and more. These slides list the many topics that we regularly talk about with our clients, and we assess using data and analytics. Over the course of this hour, we will take deeper dives into those bolder topics to show you how Merative's approach we are experts in these areas. For example, Mihil, he's going to cover how different generations are using telehealth services to address mental health conditions. This is important because despite efforts to expand provider networks to meet the growing demand, there's still a shortage of youth mental health practitioners, and closing this gap is critical. A study published in JAMA Pediatrics last year found that mental health professional shortages, as they increased, so did youth suicide rate. So for every 1 point increase in workforce shortage scores, we saw a 4% increase in youth mental health. That's even after adjusting for sociodemographic and socioeconomic factors. Quality efforts around improving mental health have included insisting patients find the right provider for them to use, both acuity-wise and a good match to address a patient's individual social drivers of mental health. Brandy will use one client example to show how we've enriched client data with social vulnerability information to focus the efforts on where to help members get the care they need. In addition to the explosion of telemedicine to treat mental health, there's also been changes in prescribing patterns for drugs to treat these conditions. I will talk in a few slides about how some of these changes have made. And this is important because these drugs can often be Schedule 2 or 3 drugs, meaning that they have an elevated risk for abuse, which can lead to addiction. Leveraging what we have learned from the opioid crisis, payers are looking to stay ahead of this by enacting utilization management criteria to review overprescribing and identify potential misuse. In addition to improving access and quality to mental health care, employers are reevaluating company processes to better support employee well-being. This includes flexibility and work from home, flex scheduling, unlimited sick time, mental health days, etc. And also a large investment in point solutions such as Lyra, Calm, Talkspace, etc., which are used to supplement EAP and medical networks. Becky's going to provide useful information on how to measure these mental health solutions and programs to determine if these investments are bringing value to patients and payers and leading to any type of cost returns. And permeating throughout all of these trends is the current regulatory environment. Ensuring mental health parity under insurance coverage is imperative for this current administration. The Consolidated Appropriations Act provided new enforcement mechanisms for departments to ensure compliance with the Mental Health Parity and Addictions Equity Act. All insurers and group health plans are required to complete compliance reviews on any non-quantitative treatment limitations and make them available on request. Departments have trained scores of additional personnel to help review and enforce compliance. According to one blog, mental health parity investigations are higher in this year than in any previous fiscal year. And this is no accident. This is because the administration is ramping up efforts to ensure that everyone gets the mental health and substance abuse disorder care that they entitled to under the law. And we at Merative have noticed an uptick in how our clients are using data to derive evidence that mental health parity is being met. There's also regulatory changes for telehealth. So we're talking a lot about telehealth today. So starting August 8th, platforms that providers use to deliver mental health care will need to be HIPAA compliant. This requirement was rolled back during the public health emergency, but very quickly will be enacted again. So payers should be working with their top mental health care providers to ensure that they're complying with this change in regulation. Payers should also be prepared to provide additional support to mental health providers to support changing care needs, care models, and not only through telemedicine, but also with the use of integrated behavioral health care and primary care. So you can talk to one of our consultants to understand how you can use data to address any of these topics. And can we move to the next slide, please? This slide highlights Merative's strategic approach to using data assets to support mental health decision-making for our payers. Our presentation today will align with these strategic pillars. And I'll show you some data for number one to track increased prevalence and increased costs in a commercially insured population. Brandy's going to talk about how we've enriched data with existing claims, but be on the lookout for some of our other data enrichment methodologies, like our medical episode grouper, which makes reporting easier and more understandable. Becky will address some of the unique challenges to measuring point solutions for behavioral health. The market has been struggling to know whether these investments are having an impact, and so we'll provide you with a framework to try and answer that question. And lastly, Mahil's going to describe an in-depth analysis conducted on market scan data on the use of telehealth. And this is a really good representation of the thought leadership that Merative strives to provide to our payer community. We try to focus on topics that we know are of interest to our clients, but clients may not be sure where to work, or they may not have a large enough population to find meaningful trends. And all of these efforts are to meet one goal, and that's to provide information to inform action. So identifying the problem is helpful and critical, but we should strive to provide information that can put actions to work, where we can put the data to work. For example, the information in this webinar is going to be used to inform benefit design around telehealth for mental health care. We are going to show you how to optimize these services. It's going to answer questions like, should you waive copays for mental health care services? We're going to show you how to use data to really target any types of efforts that you're going to do. We've measured the effectiveness of a resiliency program to make decisions on whether or not to continue investment in a certain program. So all of what we're presenting today are designed to inform action. Next slide, please. So speaking of trends, we thought we would start with a little level setting. You've heard this mentioned a few times, but mental health care need is increasing in the population. This started before the COVID-19 pandemic, but it has accelerated and exploded since the pandemic. So market scan data shows us that in a commercially insured population, the proportion of patients with any behavioral health visit has increased about 15%. The cost has increased per patient about 20%. And when we spread that cost across a whole population, the cost per member has increased 51%, or $72 PMPY since 2021. So lots of increase in use and increase in cost. Next slide. On this, for my last slide, I wanted to talk about an interesting trend that we published in our most recent Analytics Spotlight, which is a quarterly leadership newsletter we put out. We drilled down into prescribing patterns for stimulant amphetamines, which are commonly used to treat ADD and ADHD. We did this because these medications have been in shortage since the beginning of 2023. The goal here was to understand who would be most impacted by these shortages. Companies claim that the shortages are being driven by increased demand for these medications. As you can see in that top figure, that there has been an increase of use of these amphetamines, and we're also providing the trend of opioid use over the same time period. So it has been a moderate increase in the use for sure. In the chart right below, we are demonstrating and confirming that these drugs have generally been prescribed in younger boys. This trend, however, is moderating over time, and we're seeing reductions in the prescribing patterns for our youngest age groups, both boys and girls, but there have been substantial increases in the use of these medications by young adults or college-age patients. Interestingly, telemedicine is commonly used by patients with an amphetamine script. This may not be surprising, however, since patients are required to have a visit every 90 days to get a refill of these controlled medications. And telemedicine is a convenient way to achieve this. MarketScan also allows us to cut by industry. And interestingly, we see a large disparity when looking at who's taking these medications. Employees who are working in health-related fields are almost 1.5 times more likely to use these medications compared to those in the education and utility fields. So those are some interesting points I wanted to bring up about disparities, and I'm going to turn it over to Brandy now to talk a little bit more about how we're seeing disparities in the use of mental health care. Thank you.
Thanks, Leah, so much. So we're going to talk about an example with a client. So this data you're going to see today is de-identified, and it's being used with the permission from the client. The client came to us, and this was an employer. They are a national employer with locations across the United States. They came to us with wanting to better understand the populations that they have. They also wanted to really focus in on mental health and substance abuse disorders and understand where they could help their populations better. When we first took a look at their data, we focused on 3 conditions. We focused on anxiety, bipolar, and depression, and then looked overall with their mental health concerns to see what the trend was happening. We wanted to slice their data a little bit differently than we could traditionally with claims data, so we brought in other data elements. For this one, we brought in an income bracket based on where the employee and their families were living. So we could really understand, is there a difference in access to care, in utilization, in treatment patterns with that income brackets based on where people were living. As you can see from the first chart, we did not see trends that we kind of might have expected in any of the 3 conditions or in the overall mental health services. We saw just slightly less utilization in lower income households, but overall with depression and bipolar, we actually saw a trend pretty much the same across all 3 income brackets, with anxiety actually being a little bit less in the low income and a little bit less in the higher income brackets. This client also really wanted to understand with health equity, was there concerns based on their population, based on race and ethnicity? For this client, as an employer, they were not capturing race and ethnicity for the employee's spouse and child. And I know many employers I've talked to across the country, they are still struggling to capture that data, or they're working with their legal teams to bring that data in with their healthcare claims. So this employer decided to look at the race and ethnicity of the neighborhood where their families lived, so they could really better understand, is there a health equity issue and concern of their populations, and then move forward on how they could address that. If you look at the chart below, you'll see they took, again, those same claims information, and we mapped it into the neighborhood based on census data of where these employees lived. So we geocoded them down into their census tracts and block groups, and then mapped them in based on the detailed data that comes in from the census. So we have neighborhoods that are predominantly Asian, neighborhoods that are predominantly Black, Hispanic, and white. As you can see at the overall mental health substance abuse disorder, we did see higher utilization in claims data in the predominantly white neighborhoods, coming in at 160 patients per 1,000, with the Black neighborhoods coming in at 138. Traditionally across the board, the Asian neighborhoods came in extremely low, with the Hispanics following shortly behind that. With depression being one of the leading causes of mental health concerns with this population, you can see I've highlighted there in red on the bottom. When we look at depression specifically, both the Black neighborhoods and the white neighborhoods, the members living in those populations came in right about average, with 87 patients per 1,000. With our Asian neighborhoods and our Hispanic neighborhoods being quite a bit lower. So a piece of this is what the data is telling you. It is also a piece of what the data is not telling you. So here, the data for the Hispanic neighborhoods, for example, is coming in extremely lower than what we would have expected, at probably around 87 to 88 patients per 1,000. So this doesn't show an absence of depression in the community, but it probably shows an absence of patients getting help in the community. So those claims are not actually coming in the door. So if we take that data and we go a little bit deeper, so they were specifically concerned about 3 different locations across the company that we were working with. So we've labeled these location 1, 2, and 3. Geographically, they were all very different, but from the type of work that their employees did, they were very similar. And so we wanted to really understand, was there differences in the locations that they could understand? Was one location needing different services or engagement than maybe another location? You can see here, location 1 was very diverse, having both Asian, Black, Hispanic, and white neighborhoods. Whereas when we looked at the employees that worked for locations 2 and 3, they predominantly lived in only white or Black neighborhoods. Looking at the patients per depression, you'll see we've highlighted there. When we looked across the board, the patients in both location 1 and 2 were coming in very similar, with around 60 to 70 patients per 1,000 for depression. But when you look at location 3, we saw a lot more, almost twice the number of patients per depression than we were seeing in the other locations. Numbers were very similar for both the Black and the white neighborhoods. And so when we took a step further to try and drill into this to see, was this happening with the children? Was it the employees? Was it the spouse? Really, who were the patients that were driving these numbers? We were a little shocked to find that the employee was actually who was getting the services for depression. We had originally expected to possibly see the spouse, but when we dug deeper, you can see down below, we've highlighted for you, with the people that lived in the Black neighborhoods that were the employee for the plan for location 3 had 229 patients per 1,000 for depression. So that was actually almost 4 times what we were seeing on average across the average for the plan. When we looked at the people who lived in the white neighborhoods, they were coming in at 184. So we saw both location 3, both the people who lived in the Black neighborhoods and the white neighborhoods had extremely high depression. And this was something that the employer then was able to go back and work with members at that location 3 and work with the management teams to really understand what was driving this characteristic in this population. One thing Leah mentioned is we do have our medical episode grouper. So this is a Merative methodology that allows you really to take all the claims, the pharmacy data, and really understand what's going on with a patient. The really great thing about our medical episode grouper is that we can also stage out those different conditions that are going on. So for example, here we've brought depression, and you can see there's a stage 1 and a stage 2. So you can understand people that are less severe are falling into that stage 1. And as you move up the severity of the depression, you move into that stage 2. So we went and took, again, a look at location 1, 2, and 3 to really see, okay, are there different stages going on? Is there more severe depression that we need to be concerned about? You'll also see, as you look from stage 1 to stage 2, you can see the episodes that the people have per 100 members. And you can also see the costs. So again, those costs are wrapping together that whole episode of depression that's happening. So it's bringing in all the services when they're going to see the therapist, it's bringing in the telemedicine visits, it's bringing in the pharmacy costs. And so you've got all of that care wrapped up together. And the great thing is we look at this just not for depression, but across all the conditions out there. But specifically here, looking at depression, you can see when we look at stage 1 for all 3 locations, they all came in right about at the same, just under 2 episodes per 100 members. But the difference really came with that location 3 again. Remember, we saw higher rates there. When we look at stage 2, when we look at members and the episode count per 100 members for those locations, we can see both location 1 and 2 are averaging just under 4 episodes per 100 members, versus when you go into location 3, we're more than doubling our numbers there. The costs also increase quite a bit when we go into that stage 2 of depression. So a point of this is if you can keep your patients in a healthier stage and bring them back down to a stage 1 and get them healthier, it obviously is going to cost less. It's going to be more healthier for the patient, and it's going to be more productive. Taking those locations down below, we again sliced by the neighborhood where the members are living to see if there was any concerns that we really needed to understand. And so when you look down below, you'll see the cost really jump for the members that live in those Black communities in location 3. And so this allowed our employer to really start to go back and understand, why is this happening? We don't see the episode jump for those Black neighborhoods compared to the white. Actually, we see more episodes in the white neighborhoods, but the costs have quite a bit climbed. We've gone from $2,600 for members that live in white neighborhoods in the stage 2 to $3,900 for a member that lives in a Black neighborhood with a stage 2 of depression. And so this allowed the employer to sit back and go, okay, do they need to bring in more point solutions? Do they need to engage their telemedicine vendors differently to help out these populations? They went back to their health plans to start to find out, is there an access to care issue? Are there not enough providers to get them, and they're having to travel further, or they're having to travel different directions, or maybe they're going to the ER more because they don't have providers available. So it allowed questions to start to come up for the employer to really start to understand what's going on in location 3 and how can they help them. And one other way we can start to drill into the data is to start looking at publicly available data. And so we took that same population and we actually layered on the social vulnerability index. So a lot of you out there probably have started looking at publicly available data. And we know a lot of our employers and our health plans have started using this data with their claims data to really add that next level of information onto their population. And so here we've brought in that same population we were just looking at. We're still looking at them based on the neighborhood of where they live. We've brought in those Black, Hispanic, and the white neighborhoods. I've also sliced the data for you by male and female, so we can see characteristics happening a little bit differently based on the type of gender that we're looking at. And then we brought in the social vulnerability index for being below poverty. So as you move through those different percentiles for being below poverty, you can see we've got purple are the 0 to 25th percentiles, all the way over to the green are the 76th to the 100th percentile. So as you move up into those higher percentile range, those are the areas of greater poverty and more concerns. One thing that's going to happen when we start moving into an area that's higher poverty, you're not going to have doctors' offices opening up. ER visits are going to start to grow. There may not be healthcare providers moving in. There's less healthy grocery stores. Transportation starts to become an issue. You've got a lot of impact from the community that you're living in on helping to make these patients healthier and move forward. So again, when we're thinking about depression, you can see, we see typically, not surprisingly, our females are getting more services for depression than our males across all 3 types of neighborhoods, with really the lowest trend being our men that live in Hispanic neighborhoods are really we're seeing less depression coming in the door from them. It doesn't mean there's less depression happening, but this is actually an area and an opportunity for engagement, for community involvement, to work with partners and that we can outreach services to really help reach this population. And you can see there when we look at who's getting help with depression, even that 76 to 100th percentile for those male in Hispanic neighborhoods are really the lowest kind of group on the bucket there. So they're getting 4 patients with depression per 100 members, versus when we start to look at our females, even in some of those different Hispanic poverty areas, they're coming in anywhere from 7 to 10. So they're getting more help with the depression than those males. And so by bringing in different levels from the CDC's data, we can start to understand. We can look at data for transportation, for limited English speaking, for ages of, populations that have high members over the age of 65, or a lot of members under the age of 17. So there's a lot of different information we can start to look at, bringing in different layers of data to help us with our claims. I'm going to hand it over to Mihal, and he's going to walk you through some of our market scan data.
Thank you very much, Brandy. So I wanted to turn to a look at telehealth. And, our perspective is that telehealth has really fundamentally and probably permanently changed the behavioral health benefit. And that happened quickly at the beginning of the pandemic. So as we're maturing out of the pandemic, it's really time to get a more nuanced understanding of the role of telehealth in behavioral health, and to start to answer some key questions. So as Manny said, Merative has this large commercial claims database, market scan. We ran some analysis on our internal version to start looking at some of those questions. We haven't yet published this analysis, and we'll continue to do some more work. So the key questions are: how did behavioral health utilization costs change over the pandemic? The second, is telehealth a substitute or complement to in-person care? So what's its best role? 3, how does behavioral health utilization vary by subpopulations so that we can optimize the use of telehealth? And lastly, I'm calling out this question, but there isn't an answer yet, and that is, what are the impacts on quality and outcomes? So the evidence base on telehealth is, since the pandemic, is relatively thin in terms of impacts on quality and outcomes, and a few observational retrospective studies, but not really a lot of head-to-head in-person versus telehealth studies. So that's something we're still looking forward to in the future. Before I get into the analysis, a couple of things I wanted to call out in the macro environment. One, Congress, as part of the end-of-year Omnibus Reconciliation Act, decoupled telehealth flexibilities for Medicare and Medicaid from the end of the public health emergency to December 31st, 2024. We think that really sets a clock for telehealth to prove its value and establish its role sort of ongoing in the healthcare system beyond behavioral health. So that's one thing. And secondly, there was this huge surge of venture capital investment in digital mental health, including telehealth. So it was the sector that attracted the most investment. So I think it was like $3.1 billion in 2021. That has largely crashed through 2022 and 2023. So expecting a consolidation of those vendors, which then might also affect the providers available. Becky will talk a little bit more about point solutions. So as a reminder, what Leah covered, we saw this growth in mental health costs, comprised of a 15% increase in, sort of quote, access, the percent of people having any behavioral health visit in person or telehealth, combined with a 20% increase in intensity. So the number of behavioral health visits per member per year, leading to this 51% increase in allowed amounts. So that's the stage. This graph really speaks to the longevity of behavioral telehealth. So the purple line is the percent of all behavioral health visits, in-person and telehealth, that are telehealth. So big spike at the beginning of the pandemic. And then it did slowly trickle down, but really since Q3 of 2021 has stayed at about 50%. And that leads us to believe there's longevity in the behavioral telehealth is a permanent modality. A key question is behavioral telehealth lower or higher cost than in-person? So if we look at the bars on the right, total allowed amount is very similar. Telehealth 132 per visit compared to in-person 136. And both components, the out-of-pocket costs in orange, $35 for telehealth, so a little bit lower than the 41 for in-person. And actually telehealth from payer perspective, slightly more expensive per visit, $97 versus $95 for in-person. But largely the same costs for telehealth and in-person, both from a patient and payer perspective. An interesting thing in the analysis we found, if you look at 2020, is that at the beginning of the pandemic, in fact, out-of-pocket costs for telehealth were substantially lower at $16 as payers encouraged use of telehealth to continue to ensure access during the pandemic. But that really changed in 2021 and then more so in 2022. So behavioral health, telehealth, and in-person, largely the same cost per visit. And then we looked at how people are accessing their behavioral health. And so within the healthcare system broadly, there's been a discussion about the appropriate role of telehealth and in-person, beyond behavioral health, and especially in primary care. The notion being that as we emerged out of the pandemic, clinicians and patients would find the right best role for telehealth. And we sort of looked to see if it's a complement to in-person or a substitute. And so looking at the 2020 bar, we looked at 3 cohorts. One, the percent of people that had both an in-person and telehealth behavioral health visit, and that was 22%. 36% in red had only telehealth visits in 2022, and 42% had only in-person visits. So looking that in total, 78% of all people had either telehealth or in-person, only 22% both. And so really telehealth is largely a substitute for in-person visits. But then it got, and a point where we're looking at this also at for primary care, and the percent of people who have only telehealth for primary care is 5% compared to 36 for behavioral health. So behavioral health, again, telehealth, a much more important modality. But then we looked at each of these 3 cohorts and the utilization costs, and there we saw really stark, interesting differences. So the top left bar graph is the number of visits per member per year. So in-person can be considered sort of the traditional modality, at least pre-pandemic. So 8 visits per member per year. The cohort with telehealth only, 9.9 visits, sort of makes sense if telehealth is more convenient, easier access. But then we looked at this hybrid cohort and this huge increase in the number of visits. So both telehealth and in-person, 16.7. The bar graph below that shows then the impact on cost per member per year. So on the left, in-person only, lowest cost. Then you move on to the telehealth only. And as it says on the left of the slide, that cohort had 24% higher costs than in-person only. Maybe a good thing, improved access. And then this hybrid cohort, 118% higher allowed amount per member per year. So that really, of all the cohorts we looked at and segmentation of the population, this really stood out. And so the pie graph on the right shows that, yes, the hybrid population is relatively small, 22%, but accounts for 37% of the total behavioral health spend. You know, we thought, okay, is there any indication that telehealth is cost additive? So we looked at telehealth visits followed by an in-person visit, but that's really hard to gauge because of the regular scheduling of counseling in telehealth. We looked at the same thing for primary care. It's a bit easier to parse out there. But we're going to do a little more looking into that cohort. And then we also saw some interesting patterns by generation. So we looked by generation. This is the definition of each of those generations. Just calling out alpha is 0 to 12, and Gen X, Gen Z, 12 to 26. And what we saw, the bar graph on the top right, is the percent of members with any visits in person or telehealth. So starting with boomers, actually decreased during the pandemic by 10%. At the end of in 2022, 1% of boomers had any behavioral health visit. Gen X, pretty flat, and then increases in the millennial generation. Gen X, up 18%. And so when you look at the 2020 numbers, as it says on the left, Gen X now has a 2.3%, 3 times the rate of members having any behavioral health visit, 9.5% to 4.1% in comparison to boomers. And then we looked at alpha. So again, that's 0 to 12. And this really kind of astonishing increase of 69% in any behavioral health visit within that younger age group. You know, on all of this, and also this looks at the intensity, the increase in PMPY dollars. So increases across all generations, more substantially in the younger generations. And so that analysis really reinforced the focus on youth mental health. We saw today that the Blue Cross Blue Shield Association with the Boys and Girls Clubs launched an initiative to help support addressing youth mental health. And we expect, I know there's a lot of activities probably the audience has engaged in to address youth mental health. So then we looked at how are different generations accessing behavioral health services. And so the red, again, is a cohort that has telehealth only. So for boomers, 34% telehealth only, 38% Gen X, 45% millennials, so an increase in the use of telehealth only with younger generations. But then somewhat surprisingly, that reversed in Gen Z, only 30%, and then Gen Alpha, which had that big 69% increase, only 15%. So in-person modalities, more important for Gen Z and Gen Alpha. I'm not sure whether that's a preference for clinicians treating that population for in-person, more so than telehealth, or really what's driving those differences, but important to consider those in providing services to those generations. And lastly, we took a look at differences by gender. So looking at the top right, there's a difference in the percent of members with any behavioral health visits pre-pandemic, so 5.0% of men, 7.4% of women. That gap increased through the pandemic. So women had an 18% increase, men only a 6% increase. And so the difference, again, is higher in 2022, and also a greater intensity of visits amongst the female population. So as we look at the key takeaways here, in terms of that increase dramatically, costs increasing through the pandemic, largely driven by increases in the younger generations, as we looked at, and the female population. That's increases in both access, the percent of people having a behavioral health visit, and intensity. Raising the question, is that telehealth convenience related? Telehealth is a substitute for in-person, with the costs per visit being approximately the same. This hybrid population standing out as warranting more attention. And then the gender and age-specific differences, with this perhaps call to renew our focus on alpha. So more onus on employers and payers to address needs of the entire family. So Gen Z and alpha under 25, likely on their parents' benefits, and to support parents in helping to address the needs of their children, perhaps through greater work flexibility, if they need to spend more time with their kids. And lastly, a call for establishing an analytic framework to assess telehealth across these dimensions, and to look at the impacts as the evidence comes out on outcomes. What's the difference between telehealth and in-person, especially if they're really substitutes and the cost per visit is the same. This analysis is all based on claims data. So if you have access to claims data, you can replicate it. And as I said, we haven't published this analysis yet. And we'll keep looking, especially at that hybrid population. So with that, let me turn it over to Becky, who will talk about point solutions.
Thanks, Mihail. As Brandy and Mihail just demonstrated, there's a lot of variation in the use of and access to mental health benefits. And to help close some of these gaps, many health plans and employer groups have begun including mental health point solutions in their benefit offerings. Although I'm sure you all know what one is, I'm going to start this discussion with a quick definition of a point solution, just so we're all on the same page. A point solution is a standalone app or a digital tool that addresses a specific health need, in this case, mental health. And mental health point solutions can span a range of options, including mindfulness and meditation programs specifically targeted to reduce stress or increase resilience, text-based therapy, and even programs that are more or less equivalent to telehealth, either individual or group therapy. So some of the things as we talk about measuring point solutions can be used the same way to measure the outcomes of telehealth in general. Digital health apps in general and mental health solutions in particular have grown quickly in both use as well as the overall number of them since COVID and the huge investment of capital in these solutions. So most of you probably already offer at least one of these solutions to your members. And one unique quality specific to mental health solutions is that many of them are marketed direct to consumer, which means that your membership is probably already pretty familiar with these offerings. But it also means that you might not be able to measure the true impact to your population because members might be using this on your own and you have no idea. As I just mentioned, many employers and plans are choosing to add behavioral health solutions to their benefits in order to address member needs and gaps in provider availability. Many employers have found that their employees are actually asking for these solutions for both themselves as well as their children in order to address the social challenges that have emerged as a response to the pandemic. Employers see increasing mental health offerings as a way to increase employee engagement and reduce healthcare costs. And employees tend to agree. One survey found that about 2/3 of employees say that these extra services are beneficial. If you're an employer or a health plan offering one of these mental health point solutions, you probably want to measure those assumptions about how these solutions are impacting member health and employee engagement. So the first step in that process is to collect the appropriate data, whether you're specifically analyzing a point solution, or as I mentioned, looking more generally at telehealth through the health plan, outcome data for mental health interventions needs more than just medical and drug claims. So those medical and drug claims are a great initial look at program outcomes. So the highest level outcomes that you can track are cost and utilization specific to mental health, such as therapy and other sorts of ongoing care, as well as care related to acute events like ER visits. In a well-designed mental health intervention, we'd ideally see a decrease in emergency room visits and an increase in therapy and maintenance medications. That means it's possible that these programs could translate into a short-term increase in the cost associated with mental health care. Additionally, there's a handful of NCQA-endorsed quality measures related to mental health, including follow-up after an emergency room visit and ongoing care for chronic behavioral health conditions. You may be able to use some of these quality measures to ensure that you're offering a high-quality network of providers to your member population. Finally, comorbid mental health conditions are often associated with increased costs for other chronic conditions. So tracking the total cost of care for patients with mental health conditions may help identify areas where appropriate intervention helps manage total costs, even if direct costs for mental health care are stable or increasing. Excuse me. So drug and medical claims get you a good analysis, but to truly drill into the success of mental health interventions, you're likely going to want to include several additional types of data, such as workforce engagement or productivity data, like employee retention, FMLA, disability, or other types of extended leave, worker performance data, so you can really help understand how the program you're offering has impacted the employee's ability to work. And this holds true whether the employee themselves is the patient or whether the employee is maybe the caregiver for a patient, like for a minor child. Health risk assessment and other survey data can be another source of absenteeism data, and it can also help provide self-reported presenteeism data, as well as insights into questions around mental state, stress, and feelings of resiliency. And finally, for payers who offer ACOs or otherwise have access to provider data, PHQ-9 assessment data can offer quantitative clinical outcomes to include in a point solution effectiveness analysis. So the PHQ-9 is a standardized screening for use in a physician's office, and for those of you with access to that sort of data, this can allow analysis on a broader range of members, especially compared to an HRA, which is often for the contract holder. You'll have PHQ-9 potentially for the entire family. Merative recently took this approach for a program evaluation of a resiliency program offered by a large employer we work with closely. This organization offered a program intended to improve worker resiliency. Sorry, my slides have a life of their own. This employer wanted to, the organization offered a program intended to improve worker resiliency, and they really wanted to understand the return on investment and also what sort of value was provided to employees and their families. So to measure these outcomes, we took a difference in difference approach between participants and a matched cohort of non-participants. And for this particular client, we used the employer's data for both the participant and the non-participant group, but we are able to match participants to market scan if there's either not a large enough group of non-participants or potentially to mitigate any selection effect for the program participation group. So looking across the metrics I discussed on the previous slide, we found that participants in this program increased their use of medical services, resulting in a higher trend and increased rates of diagnosed depression in the participant population, although participants also demonstrated decreased use in high acuity care like ER visits. Additionally, when we looked beyond claims data, we could see additional value in the program, seeing improved self-reported responses related to feelings of value and purpose, and lower trends in lifestyle risks compared to members who didn't participate in the program. So this employer is a really good example of how evaluating data beyond medical claims really helps demonstrate the program effectiveness, even when we're seeing that increased short-term costs. And now I'm going to turn back over to Manny to close us out for today.
All right. Thanks very much, Becky, and thanks to all of our presenters. I'm going to be very brief here. I want to reserve some time at the end for Q&A. I saw a few questions come through. So, and as others are getting their questions ready, just wanted to introduce a quick poll question. I'll ask Adam if he can bring that up on the screen. About 6 months ago, we hosted a similar webinar about 2023 trends. And at the time, we asked attendees what topics would they be most interested in hearing about from Merative. As I said earlier, our team here is always researching different topics on behalf of our clients, and we occasionally make that available in venues like this webinar, blog posts, etc. So please just take a quick second to fill out this poll and let us know what you want to hear about the most in future Merative content. And I'm not sure if that poll will stay up as I move to the next slide, but I'm going to just talk quickly about our next webinar, which will be taking place on July 18th. We'll be hosting a webinar through the AHIP organization. So if you're a member of that organization, you can follow the link that's in the resources section of this media player here, or go to the URL on the top left. So Tuesday, July 18th, 1 to 2 p.m. Eastern time, we'll be talking about the transparency and coverage rule. It will feature a few of our experts on that subject, Brian Briegel and Mark Gillespie. They have more than 15 years of experience in the subject of price transparency and decades more in CMS regulations. So really the right people to talk about what you need to know to comply. And they'll also share insights informed by our work helping clients to comply. And attendees will also receive a compliance checklist. So definitely worth signing up for that if this is an important consideration for you heading into 2024. But with that, I'm going to turn it back over to Adam and see if we have any questions from the audience.
Thanks so much, Manny. We do have a few that have come in. The first one is, and I think, Leah, you might have addressed this a little bit earlier, so I might direct this towards you, but post-COVID and looking into 2024, where do you advise employers or plans start to properly assess their population's behavioral health needs?
Based on what we heard today, and what we've been working with, I would take a few steps. First would certainly be a focus on youth mental health. So I would understand networks and need around youth mental health and work internally to understand and come up with creative solutions to potentially address that gap. We know that, at least in our youngest populations, as Michal showed, that virtual care solutions may not be the best way to move forward here. So considering things like integrated behavioral health care with primary care, especially for those payers that have good access to primary care networks and have some control over that. So that might be one of the first things we would think about. Then as Becky had mentioned, many of the solutions that we mentioned today are probably in play at a lot of the organizations that are represented here today. I would go back and understand my goals as an organization to understand how we're going to move forward with those solutions. So are we going to measure them? If so, what's the plan for doing so? And setting up that measurement strategy, maybe using some of the insights that we gained here today. So I think those would be two of my first steps, but of course there's many more.
Thank you so much, Leah. Second question coming in here says, in your analysis of in-person only versus telehealth only versus hybrid, did you see if people were being treated for different conditions?
Yeah, let me take that one, Adam. So we did take a look. So, what's driving the increased intensity in the hybrid cohort? So we looked at the conditions across all three and really saw a striking similarity. We expected to see perhaps conditions that are more severe in that hybrid cohort. We didn't see that. It was across all three: generalized anxiety disorder, adjustment disorder, major depressive disorder. So it didn't explain the differences we saw in cost and utilization. But thank you for the question. We'll keep looking.
We had a follow along to that question too that asked about, did you look at risk scores for these cohorts?
We didn't. That's a good. So we didn't look at overall sort of relative risk score. to see if there are comorbid conditions that are driving some of that increased utilization, but that's a good potential next step.
Awesome. I think we have time for maybe one more question here. Asking about, have you done research into how many video visits were immediately followed by an in-person visit? I guess that might go to you as
just
well.
on the analysis we did, Adam, we did. I mentioned that briefly, but with behavioral health, because visits are regularly scheduled, the notion is if you have a telehealth visit followed by an in-person visit, was the telehealth maybe unnecessary, just triage? But with the regular scheduling of behavioral health visits, it's a little harder to make that judgment. But we did look at that for primary care. And all permutations of that, in-person visit followed by telehealth. And there's some interesting patterns that we'll probably write about in a blog post.
Awesome. I think we are finally at time, or maybe even a little bit over time. So really appreciate everyone's time today, and thank you all so much. To our presenters, thank you so much for the fantastic webinar and for sharing all your insights and expertise. Thank you so much to the audience for your time and participation in today's webinar. This concludes today's webinar, and thank you again, and enjoy the rest of your day.
Thank you.